Hello everyone, this is Sarah Myers, and today we're going to talk a little bit about polycystic ovary syndrome, which is better known as PCOS. PCOS is a complex metabolic and hormonal condition with three main characteristics. These include androgen excess, ovulatory dysfunction, and polycystic ovaries. Not every woman will have all three of these characteristics, but we'll discuss those a little bit later on in the video. PCOS affects approximately 1 in 10 women of reproductive age. This condition does not discriminate and then affects women of all races, ethnicities, and socioeconomic backgrounds. Symptoms of PCOS include irregular or missed periods, acne, excess hair growth, weight gain or trouble losing weight, trouble getting pregnant, darkening of skin, pelvic pain, male pattern baldness, insomnia, and fatigue. Although these are common symptoms seen in PCOS, not all women will present with these symptoms. For example, one woman may have all of these, while another only has one or two. PCOS is associated with several comorbidities. As many as half of the women with PCOS have metabolic syndrome. This can be responsible for the central obesity and darkening of skin seen in many women with PCOS. Women that have PCOS are at a much greater risk of developing type 2 diabetes. 50% of these women either have or will develop this disease. Depression and anxiety are also very common. These women are at a greater risk of developing heart disease and must have their blood pressure and lipid levels checked regularly. Studies have also shown that these women are 3 times more likely to develop endometrial cancer. Women are also at a greater risk of developing non-alcoholic fatty liver disease, as well as sleep apnea. With all of these common signs and symptoms, you would think that PCOS is easy to diagnose, right? Wrong. Of those 10% of women that I mentioned earlier, half of those will be misdiagnosed or not diagnosed at all. So why is PCOS difficult to diagnose? PCOS is a diagnosis of exclusion. Okay, great, but what does that mean? That means before a woman can be properly diagnosed with PCOS, her provider must first rule out pregnancy, thyroid dysfunction, hyperprolactinemia, congenital adrenal hyperplasia, Cushing's syndrome, and ovarian tumor. After excluding other diseases that present similarly to PCOS, the Rotterdam criteria can be used to properly diagnose the disease. Remember in the beginning of the video when I mentioned androgen excess, ovulatory dysfunction, and polycystic ovaries? This is where the diagnostic criteria comes in. I have included other diagnostic criteria, but the Rotterdam criteria is currently recommended by the Endocrine Society. It states that a woman must have 2 of the 3 following criteria: ovulatory dysfunction, androgen excess, and polycystic ovaries. And it can be a variation of any of the 3. If a woman has ovulatory dysfunction without androgen excess and vice versa, an ultrasound of the ovaries is warranted. Ovaries are considered polycystic if they have 12 or more follicles, ranging from 2 to 9 millimeters, or if the ovary measures greater than 10 milliliters. Diet and exercise is the first line of treatment in all women with PCOS. Further treatment must be tailored to each individual patient based on her symptoms. Hormonal contraceptives can help regulate cycles, decrease acne, and reduce the risk of endometrial cancer. In women with anovulation that are trying to become pregnant, Clomid can be given to induce ovulation. Women with glucose intolerance can be prescribed metformin, which may also help with weight loss and ovulation. We must be able to take detailed histories and complete comprehensive physical exams on these patients because proper diagnosis of PCOS is largely based on clinical presentation. We have to be able to connect the dots even when symptoms do not seem to be related. By using our clinical skills, we can properly diagnose this disease in a timely manner and reduce the health disparity of underdiagnosis. Thank you for watching.